Thanks for doing this, Dr. Umbrella. We really appreciate your time.
Thank you very much. I'm glad to be here today to talk to you about systemic JIA and some research updates. So as Mrs. Cupp said, I'm an investigator at the National Institute of Arthritis and Musculoskeletal and Skin Diseases, where I run a research protocol studying the natural history of systemic JIA and adult onset Still's disease.
Dr. Umbrella, I'm going to jump in for a second. You're in presenter mode. Would you like to be in presenter mode, or do you want to show one slide at a time? You're good.
There you go.
Thank you.
Yep.
So I have no conflicts of interest to disclose with respect to relationships or investments or companies or anything of that nature. So just to give you an overview of what we're going to talk about today, as I thought about updates in research and things that are important in systemic JIA, I kind of broke it down into 4 general questions. There's a lot of other questions and there's plenty of other research we could talk about, but I mean, there's, in my mind, really 4 things that I wanted to talk about today. The first one is, what is systemic JIA or SJIA? And I think if I understand correctly, Dr. Canna probably had a great talk where he regaled you with information about systemic JIA. So I'll touch on some of those things and maybe address a few specific points as they relate to research. The second question is whether there's a therapeutic window of opportunity in systemic JIA, a time that we can treat that will change what happens down the road with respect to the disease course. The third question is whether there are ways that we can personalize the treatment of systemic JIA, identifying specific individual factors that help us to find the right treatments that will be most effective for one specific person. And finally, can we predict who will get systemic JIA lung disease? And there's a story that many of you have probably heard that we'll talk about a little bit with respect to the lung disease that's been relatively recently recognized with systemic JIA. So the first question, what is systemic JIA, is you can take it as a literal question or you can take it as a philosophical question. Technically speaking, systemic JIA is a classification criteria, a group of rules that we use to categorize people with arthritis. And so systemic JIA is a systemic inflammatory disease within kind of the group of JIA. If we go back to when it was first described or recognized, it was recognized originally by Sir George Frederick Still. And this is a photograph of one of the patients that he described in his original paper. At that time, there weren't steroids and there weren't good anti-inflammatory medications. So this was the disease course. The arthritis became chronic with contractures of the joints. The inflammation was consistent and they weren't able to stop it. So the liver and the spleen continued to enlarge. The children lost weight. And the natural history of the disease is terrible. And thank God that we are not dealing with that natural history of disease any longer today. However, it's important to recognize that that's where we started. Arthritis was a central and pivotal part of this phenotype that was originally described. And so as the definitions have evolved over time, we've gotten to this place where we now have SJIA as the thing that's a surrogate for what Dr. Still originally recognized. And that's the presence of chronic arthritis and fever, those 2 things, plus one or more of the additional characteristics that are the very typical salmon pink rash that gets worse with the fever and better when the fever defervesces, generalized lymph node swelling, swelling of the liver and the spleen, and inflammation and swelling of the linings around the organs, around the heart, around the lungs, and around the abdominal organs, the viscera. And so, although systemic JIA only accounts for about 10% of cases of JIA, it disproportionately accounts for the morbidity and mortality within JIA, the severe cases of JIA. And beyond the classification criteria, systemic JIA has phenotypic heterogeneity. And what this means is that there's clinical features that are different between different people with systemic JIA. And this is characterized by different disease courses, a variety of different complications, some of which have been described and others of which haven't, and different responses to treatments, which may be an inherent obstacle in the end to identifying causes to this thing we call systemic JIA, the fact that there are these differences. Second of all, it's a rare, genetically complex disease. What that means is that there are genetic factors that contribute to the development of systemic JIA, but they're not straightforward. It's not generally inherited in families the way that some of the monogenic autoinflammatory diseases like familial Mediterranean fever or HIDS are inherited in families. And finally, we recognize that it's marked by inflammation, which is really the innate part of the immune system. The innate immune system is hyperactivated. And so although there are things that we don't know about it, we do know that it involves innate immune hyperactivation. Now, specifically, the innate immune activation is present early in the disease course in everyone who's affected. As the disease progresses, sometimes that inflammation changes. So the course of inflammation can follow three distinct patterns. The first is the monophasic course that consists of a single episode of inflammation that never recurs after it resolves. The second is the polycyclic course that involves these recurring episodes of inflammation that are separated by periods that are free of inflammation. And finally, there's the persistent course that displays inflammation that's more continuous than episodic, never really reaching an inflammation-free state. The inflammation can improve when treatment is given, but as treatment's tapered, the inflammation immediately recurs. Estimating the proportions of these three patterns have produced pretty wide results across studies, but one study, and the one that people commonly quote, found that 40% of cases were in the monophasic range, around 50% of cases were persistent, and under 10% were the polycyclic disease course. And importantly, across these, about half of children with systemic JIA develop a chronic arthritis regardless of the type of treatment that they receive. And there are emerging studies from different groups around the world that are kind of demonstrating that the numbers are give or take 5%, around 50% in their cohorts for people who continue to have arthritis despite treatment. SJIA is also marked by these heterogeneous complications or phenotypes that I mentioned, some of which are life-threatening. These may include ones that we know about, like pericardial effusions or fluid around the heart, which can happen in as many as 40% of cases. Macrophage activation syndrome, which was historically the sinister complication of which we were the most afraid, which could happen into a third of the cases in an occult way, and perhaps under the surface in an even larger proportion. And then this highly lethal form of lung disease that's only recently been recognized and reported. But in addition to the pericardial effusions and the macrophage activation syndrome and the interstitial lung disease, like I mentioned, half of children have a severe destructive arthritis. Cohort of patients have bowel inflammation that looks like inflammatory bowel disease. Some children also develop skin manifestations that can include blistering rashes or other rashes that aren't the typical salmon evanescent skin rash. And then kind of some common inflammatory features like growth delay or osteoporosis or amyloidosis, which can be related to chronic inflammation, maybe together with the chronic effects of steroids. So when you start to consider this variability that exists within systemic JIA, both in the disease course and the complications, as well as the fact that different patients respond differently to the medications that we use, it raises the possibility that we're not dealing with a single disease or a single condition, but rather we're dealing with a group of conditions that reach a common endpoint, which is this inflammation that affects the joints and the lymph nodes and the skin. And in fact, this could be caused by a variety of different molecular causes, resulting in this common endpoint. And that's kind of the hypothesis that I have in my research protocol and the approach that I take to studying the genetics of systemic JIA, to try to use genetics to see if we can disentangle the different elements of systemic JIA. And so when we think about this, what is systemic JIA from the clinical perspective, the information seems to suggest that it's not a single condition. And this is a bit of a problem when we do research studies, because when you do a research study, you want to have a bunch of individuals who have the same thing with the same cause, and you study them together and you get clues about that same cause. If we think we're putting people together who have features that are similar, but perhaps causes that are distinct from one another, then it's possible we won't find anything if we put them all together and study them. So while what is systemic JIA is philosophically an important question, when it comes to research, it's critical that we're defining these groups of people correctly as we put them into studies and spend time and money to dig deeply and try to find what's in common among them. So looking beyond what the clinical things can tell us about what is systemic JIA, what have the genetic studies of systemic JIA told us to date? And so the first thing, and I mentioned this to you, but familial inheritance of systemic JIA is not typical. It's atypical. It does happen, but it's not typical. And my feeling and the feeling of our groups at the NIH is that when this happens, it's very often a monogenic autoinflammatory disease and is taken out of the group of systemic JIA and given a new name for what it is. There's several examples of families or individuals with systemic JIA who've been shown to have and published mutations that cause their or are suspected to cause their systemic JIA phenotypes. And the one example that's the best known is the mutations in the LACC1 LAC1 gene, which codes for a protein called famine. And mutations were found in families in Saudi Arabia that segregated perfectly with the presence of a kind of arthritis that looked like systemic JIA. So it's important that we consider that some cases may have single mutations as the cause, but we don't often see it inherited in families. The second thing that we learned from genetics is that systemic JIA is not purely autoinflammatory. So when we took a big cohort of systemic JIA cases from around the world and we studied their genetics, we looked at genetic variants and how frequently they occurred in kids with systemic JIA and how frequently they occurred in healthy kids taken from the same populations. And what we found was that there was a specific immune marker of the HLA-DRB1 gene that was highly associated with systemic JIA, seeming to confer an odds ratio or a risk of over twofold for people having systemic JIA if they had that risk allele. The thing about that immune marker is that it's not a part of the innate immune system which controls the inflammatory responses. It's actually a part of the adaptive immune system, or the part of the immune system that takes pieces of foreign proteins or pieces of self proteins and processes them and presents them and then shows them on their surface to T cells, T white blood cells, which can then form a specific immune response to the things that are being presented. So the HLA-DRB1 variant that we found is actually one of those scaffolds that holds pieces of protein peptides for presentation by T cells. So by bringing T cells into the mix, we're saying that this is also involving the adaptive immune system. And so the counterbalance to the term autoinflammatory disease in the innate immune system is the autoimmune disease in the adaptive immune system. And so this gets to the question of whether systemic JIA is autoimmune or autoinflammatory. In my opinion, that's a straw man. That's a false paradigm, because I think that there's elements of both parts of the immune system that are involved with systemic JIA. And finally, the third thing I'll mention that we've learned about systemic JIA from genetic and genomic studies is that it's distinct and different within the family of JIA. Under the umbrella of JIA with the 7 mutually exclusive subtypes, systemic JIA is already set apart by its systemic inflammatory features. However, when we take the genetic signature of systemic JIA, the genes that have variants that occur more commonly in the kids with systemic JIA than the controls, and then we compare that pattern to the same genetic association type of data from the other types of JIA, it's very clear that the signature, the genetic architecture of systemic JIA is distinct. And we published this several years ago. And at the time, we were excited, but at the same time, some of the response was, so what, because the clinical features suggest this. But if you look at the way we treat systemic JIA historically, we take the medicines from those other conditions and we use them in ours. But if we know it's different, then maybe that shouldn't be our approach. And I think we've started to move away from the repurposing of poly-JIA or seropositive rheumatoid arthritis drugs in systemic JIA. So beyond genetics, there's also questions about the immunology of systemic JIA. Now, when I think about the immunology of systemic JIA, I'm not embarrassed to admit that I feel a little bit like the blindfolded scientists here. Of course, I'm the idiot who's standing in front who keeps mumbling about genetics as everyone else is doing what they can to kind of interrogate and study the innate immune system. But in reality, our understanding of systemic JIA is piecemeal, just like this. For example, we know that IL-1 beta, the inflammatory cytokine, is important in systemic JIA. We have colleagues in Germany who've studied a group of inflammatory alarmin proteins released by dying or injured cells called S100 proteins, and these seem to be a biomarker that goes along with the disease activity of systemic JIA. We wonder whether these danger signals may actually be part of the drivers of the inflammation in systemic JIA, but that hasn't yet been demonstrated. We recognize that there's a variety of different cellular abnormalities in systemic JIA, both in the innate immune cells like monocytes and the adaptive immune cells like T cells or B cells. Additionally, many people are trying to identify what is the specific cell type that's abnormally driving the disease in systemic JIA. Of course, within the immune system, when you derange one thing, that has effects that fall downstream towards many other things. So it's possible to jump in just like these doctors with the elephant and identify something that's different. But then the question becomes, is this thing different because the primary problem in systemic JIA has shifted things and made it different, so it's a secondary effect? Or is this part of the primary problem that's driving systemic JIA, which would make it the primary effect? That's a critical point, because as we try to cater therapies or identify specific therapies that are going to treat systemic JIA in the best way, we'd ideally like to get to the root of it, to treat the cell or the gene or the protein that's actually initially causing the problem. So we don't know what the cell is, but we're looking at many different kinds of cells. So we recognize, in addition to cellular abnormalities, that there's specific cell responses that are involved. And what I'm referring to in this particular one, TLR, is the toll-like receptors, which is a group of innate immune receptors that recognize pieces off of bacteria. And in fact, this is important because there was a study that looked at kids with systemic JIA, and it found that when their cells got stimulated with lipopolysaccharide or components from the bacterial cell walls, the pathways that were involved with responding to those were abnormal in kids with systemic JIA. Additionally, when they just looked at the gene signatures, the genes that were turned on and off in blood samples from kids with systemic JIA, it was pretty clearly affecting the pathways that were also involving responses to these sorts of bacterial products. And then, of course, there's interleukin-18 and a number of other emerging cytokines that are being studied with great interest in systemic JIA. And all of these represent unique and potential therapeutic targets. But the problem is we don't know which of them is the driver. And so in a certain way, we're blind in our treatment the same way that we're blind in our discovery. And of course, all of these elements can get put into some very busy figure like the one that I'm showing you right here that integrate the findings. The thing about this to me is that this starts with the number 1, right? You see the number 1, but that's not really the number 1, because the number 1 should go at the driver. So the number 1 is just the place where they want to start telling the story of this figure. To me, the real story of this figure is that systemic JIA starts with a lot of inflammation and innate immune activation. And over time, the adaptive immune system, or the B cells and T cells, more T cells than B cells, start to show a change in the way that they're behaving, and they become hyperactivated and become an inflammatory type of T cell that in the end seems to drive the second or the later part of disease that may involve more of the chronic arthritis. Again, as we're studying these things from a focused perspective, I'm interested in cytokine A, B, or C. I can make observations about cytokines A, B, and C. The types of studies that I'm interested in try to take a step back and look at the whole picture and say, which of the things in this entire pattern, in this entire group of cells, population, are the ones that we should focus on for our more intensive investigations. So from a genetic and immunologic perspective, what is systemic JIA? I think the genetics suggests that it's more than one condition, and I would argue that much more work is needed, with the caveat that in the study that we're conducting at the NIH, we've looked at about 45 people with systemic JIA at this point, and we've identified things that could plausibly be causative mutations in more than a third of them. But in all of those people, we don't find the same gene mutated in any of them. And so this kind of supports the hypothesis that actually there's a number of different molecular ways to arrive at the same common endpoint. And so the way to do this is to study more people, is to get more people involved and to do more sequencing and collaborate together, and then put everyone's data together and see if we can find people with more than one mutation in a gene. Because once we find that, then we have more evidence to write grants or to invest money to build models to study those specific mutations. As you can imagine, when you're sitting on 15 or 20 mutations in different genes, it's very difficult to garner support to deeply investigate any one of those. And from an immunologic perspective, we haven't identified either a primary mechanistic abnormality or cellular driver. And so the immunologists continue to look for those things. The next question I want to address is whether there's a therapeutic window of opportunity in systemic JIA. And so this question kind of comes from a perspective about the treatment of systemic JIA. And so this timeline demonstrates some of the important events in the development and use of the cytokine inhibitors for the treatment of systemic JIA. It's clear to me and hopefully to everyone in the room and everyone who treats systemic JIA that these medications have revolutionized the treatment of systemic JIA. However, they're not perfect in the real world, as I mentioned, because real world cohorts show that up to 50% of people continue to have active disease after 2 years of treatment. And so the question is, how can we do better? And so if you look more carefully and you focus at this time point for a minute, this represents the first time it was shown that anakinra can be effectively used as a first-time treatment for new onset systemic JIA. This represents 2014, about the same time that Peter Nigrovich wrote a thought-provoking editorial in Arthritis and Rheumatology, where he wondered aloud whether there might be this therapeutic window of opportunity in the treatment of systemic JIA, meaning a time when you could treat aggressively and alter the long-term or longitudinal trajectory of the disease. And again, this was rooted in the biphasic nature that I just alluded to, where there was early innate immune activation with fever and inflammation that transitioned over time to less of the acute inflammation, but more of the chronic arthritis. So it followed that if one could stop the acute inflammation at the beginning, maybe one could stop the effects of the acute inflammation on the T white blood cells and stop the affected arthritis as a result of shutting down that T cell mediated inflammation. And this hypothesis made sense in the context of the fact that 6 months represents an important prognostic time point. There are studies that showed that people who have active disease or who continue to have fevers and receive prednisone treatment have much worse outcomes with their systemic JIA than people whose disease is brought under control within 6 months. So we recognize that treatment in the first 6 months seems to be important. And when this was coupled with the fact that there were some promising studies both in the United States and in the Netherlands that looked at the early use of anakinra and found that they were able to quench inflammation early, this hypothesis has garnered more support and has become more popular. So spreading from these observational clinical studies, Lauren Henderson and her group in Boston recently did a study where they looked at the T cells themselves in kids with systemic JIA over time. So on the left, you're looking at kids with healthy kids who don't have systemic JIA. And what they characterized in them was the T cells, specifically the anti-inflammatory regulatory T cells. What they find is that people who have systemic JIA and acute inflammation start to have a loss of their regulatory T cells, and they start to take on features more of the Th17 inflammatory T cells. And as the systemic JIA moves from the acute inflammatory phase into the chronic phase, those regulatory T cells are further diminished, and the signatures become even more Th17-like, moving those Th17 cells into the effector Th17 cell, which does the bad inflammatory business. So really the take-home message of this was an attempt to do a functional study looking at the T cells themselves to see if one could identify a signature that would support evolution of T cells from an anti-inflammatory type of T cell population without systemic JIA through an intermediate phenotype in the acute systemic JIA, and then into the chronic pro-inflammatory Th17 cells in the more chronic form of systemic JIA. Another recent study looked at this from the clinical perspective, and they did so by looking backwards. By looking backwards at a group of patients that they treated with early anakinra treatment, they were able to identify that there was a difference between the patients who received early anakinra and the patients who received late anakinra. In this study, they were looking at how likely individuals were to be in clinically active disease or remission off of steroids 6 months after they started their treatment. So at whatever time point they started their treatment, their end point was 6 months after treatment. And each dot in this graph represents a time point when treatment was started for a person. And on the y-axis on the left here is the probability or the percentage of effectiveness shown by this graph. So, but in truth, people either responded and are 100%, or they didn't respond and they're 0%. And what you'll notice is that there's a pretty dense distribution of the responders on the left and a more sparse distribution of non-responders on the left as compared to the right. But from a statistical perspective, what this really demonstrated is that the response to anakinra at 6 months is much better if they're treated within the first 3 months of disease onset. Somewhere in the ballpark of 92% of cases that were treated within the first 6 months, within the first 3 months of onset, made their way into clinical remission at 6 months. And that's as compared to less than 40% of those that were treated after the first 3 months that found their way into remission. And so this is a small study, and this is from a single center, so it's not definitive, and it warrants further prospective investigation. But nonetheless, these observations do seem to support the notion that there's an early opportunity to actually change the trajectory of the systemic JIA with early treatment. And so, as with all studies of systemic JIA response, it's important for us to keep in mind that the expected contribution of monophasic systemic JIA is part of the observed effect. And what I mean there is that if 40% of cases of systemic JIA are monophasic, then you expect that there should be 40% of patients who respond to whatever you give them and that their disease goes away. And so, as you're looking at treatment responses, you have to keep in mind that if they don't have a response of more than 40%, then it's possible that the effect that you're seeing is only due to the monophasic patients who you would expect to respond anyway. So for the people who received therapy after 3 months of onset, the risk was almost 8-fold lower, or the chances of achieving clinical remission were almost 8-fold lower than the people who received treatment during their first 3 months of disease. So with respect to the therapeutic window of opportunity in systemic JIA, I would say that preliminary studies support the idea in at least some cases with both clinical evidence through retrospective study and early pilot functional studies that show evidence that's consistent with that hypothesis. So turning our attention to question number 3, whether it's possible to personalize the treatment of systemic JIA. If there's indeed a therapeutic window of opportunity, then it would be highly advantageous for us to match individual patients with the medicines that are most likely to quickly and effectively induce a remission in their systemic JIA. And so to accomplish this, ideally, we would identify easily observable biomarkers that would be predictive of treatment responses. So while we were exploring the IL-1 receptor antagonist locus in systemic JIA, we came upon something. IL-1 receptor antagonist is the protein that is anakinra. It's produced in a recombinant way and administered exogenously. And so we were surprised to see that there was a relationship between genetic variants of the IL-1 receptor antagonist and systemic JIA, but we immediately wondered whether these might make people make more or less IL-1 receptor antagonist, and almost a direct line between the risk factor and the mechanism through which it causes disease. And so to try to look at that, we went and looked at some studies that had looked at the levels of either the IL-1 receptor antagonist gene transcript, so how much it's being produced as RNA, or the levels of the protein itself in the blood. So we looked at 3 different studies that had looked at that. What you're seeing in these 3 studies is a bunch of genetic variants. Each dot represents a variant that were shown at some level to correlate with the level of expression of IL-1RN. And within these variants, these ones up here, which correlate with high expression on this side, and these which correlate with low expression on this side, the genetic variants of interest to us are tagged in green if they were present less commonly in cases, or we'd call those protective, or they're in yellow and red if they were risk factors or present more commonly in systemic JIA. And of course, what we're seeing here is that the either protective or risk factor variants are strongly correlating with changes in expression in IL-1 receptor antagonists. Specifically, there's low levels of IL-1 receptor antagonist expression with the risk factor SNPs. And this makes sense because if you make less of this anti-inflammatory chemical, then you would expect it would lead to an inflammatory condition. And so everything made sense. But at the same time, we wondered whether or not high expression alleles might also correlate with non-response to giving this protein exogenously, to giving anakinra. So if a person already has high levels of anakinra or IL-1RN in their blood, then giving them more might not be expected to help. So to look at this, we analyzed 38 kids from the in-charge cohort from the United States clinic who had received anakinra. And what we found was, lo and behold, people who had 2 copies of the high expressing variants really didn't respond well to IL-1 receptor, IL-1 inhibition at all. Now, in this case, we weren't looking at canakinumab, we were actually looking at anakinra alone. But in any case, we found that it was highly sensitive and relatively specific. So almost everyone who had 2 copies of the high expression alleles was a non-responder to anakinra. So in the wake of this finding, there have been 2 other studies that have gone back to their cohorts and looked backwards to see whether these genetic variants correlated with responses to treatments. One of those, the first, was a German study that looked at 61 subjects. And this study didn't correlate with response to systemic JIA. These genetic variants didn't correlate with response to anakinra in systemic JIA. Now, there's a number of reasons that this could have happened. Of course, the first is that it's possible that the observation that we made is not true and that these don't correlate with expression. But in addition to that, you have to note the fact that the IL-1 receptor antagonist association that we identified wasn't seen in the German population. It was seen in every other population, but in the German population, it really wasn't present. Additionally, when we did our study, we looked at non-response because of an idiosyncrasy of our data set. And the German study did not look at non-response, they looked at response. And those 2 things are not interchangeable for a statistical reason. And finally, they didn't look at the individual SNPs, the individual genetic variants. They looked at the SNPs in group, which when we looked at the SNPs in group in our study, we didn't see the same strength of association as we saw when we looked at the markers individually. So there were a few differences between the studies that could explain why they didn't identify that association. And if it were only those 2 studies, then I wouldn't be touting this quite as strongly. But relatively recently, there was a study published by an Italian group that looked at 54 subjects and found that in their cases, indeed, the same group of IL-1 receptor antagonist variants did correlate with non-response to anakinra, somewhere in the ballpark of an odds ratio of 6 to 7, which is in the same range as what we had identified in our original cohort. And so at this point, I would say that it seems that there's mounting evidence in support of using IL-1 receptor antagonist variants as treatment biomarkers to identify people who may be expected to not respond to anakinra or canakinumab and avoid going down that road and wasting time. Beyond genetic markers, gene expression signatures and serum biomarkers can both potentially predict treatment responses in systemic JIA, and there are several real-world examples that have recently been published. The first is a reanalysis of a gene expression data set from an earlier trial of canakinumab, where they found that there was a gene expression signature that seems to correlate with response to canakinumab treatment. This was from Grant Schulert's group. The second was a study from the German group that examined active systemic JIA cases in an open label study of canakinumab, where they used an array that looked at a lot of different serum biomarkers. And they found that there was a correlation between high levels of IL-18 and low levels of CXCL9 in the serum and responsiveness to IL-1 blockade. Now, all of the studies that I've mentioned have been retrospective. So the first place that we need to go for any of these observations is to design a prospective study where we administer treatment and check these measures at the same time. But nonetheless, these studies reflect the ongoing and emerging efforts to identify strategies to uncover novel indicators of therapeutic response that can help us to guide the treatment of systemic JIA. So if our efforts to achieve personalized medicine are successful, and we're able to treat our patients to the point where they reach prolonged clinically inactive disease, then the question is, what do we do? And we all look at each other about this, because there's some people who say, I want to help my patients to stay in remission, so I want to keep them on their medications. And there's other people who say, I don't want to expose my patients to these unnecessary medications, so I want to make sure that they're necessary, so I want to try to taper those medications. And I don't know if we have an answer about which party in this argument is right, but then we have patients who want to get off the medicines if they don't need them, or want to stay on the medicines because they don't want to risk flaring. And so it becomes a conversation, but we don't have a lot of data to drive us at this point. So there's a recent study that was undertaken that tried to get at this question. To evaluate this, a group from France performed a two-part open label study where they randomized people who had achieved a clinical remission into a trial. So 182 kids with systemic JIA were enrolled into this trial. They got canakinumab. If they were able to discontinue their glucocorticoids and methotrexate and get onto only a canakinumab monotherapy, then they were able to be entered into this second stage of the study. The second stage of the study was basically designed to see if they decreased the dose of canakinumab over time to discontinuation, would the kids be able to remain in remission? And then in the other arm of the study, if they decreased the dosing interval instead of the dose itself, would those children be able to remain in remission? Of the 75 subjects that discontinued the methotrexate and the glucocorticoids, and were ultimately randomized into part 2 of the study, only 33% of them were able to maintain the clinically inactive disease off of the canakinumab. Now, at this rate, it's possible that these subjects that maintained the clinically inactive disease off of canakinumab were only the monophasic patients, right? This could lead to the conclusion that it's not beneficial to attempt the dose reduction for the subjects on canakinumab. However, I might challenge this notion, because even if such an attempt to taper would only lead to discontinued therapy for the monophasic patients, that's still 30 or 40% of patients who are going to stop receiving a medication that they no longer need. And so the real bind at this point becomes, can you recapture the effectiveness or the clinically inactive disease with therapy by reinstituting therapy if someone flares during tapering attempts? So going forward, I think it's very important that we try to clarify whether it's possible to reclaim clinically inactive disease following a failed attempt to taper therapy. And so with respect to the question, can we personalize the treatment of systemic JIA? I would say that we're continuing to move towards the use of biomarkers to guide the treatment of systemic JIA. I think that there's a number of different types of biomarkers that are in play. And I think that there are several groups that are doing prospective studies, designing or implementing prospective studies to answer these questions. Now we'll pivot for the last few minutes to discuss a new observation related to the emergent lung disease and systemic JIA. And so the question that I'll pose for this is whether we can predict who will get systemic JIA lung disease. Or another way to think about it is systemic JIA lung disease something more than just lung disease? And I ask it this way because the lung disease of systemic JIA was first reported almost a decade ago now in a relatively small study that looked at pulmonary hypertension and abnormalities. But that first study by Yuki Kimura and colleagues led to recognition and screening. And through that process, it was recognized and discovered that there was a small but significant group of systemic JIA patients who developed a form of lung disease while getting treatment with systemic JIA. There have been two reports that have looked at it, one that was led by Vivian Saper and one that was led by Grant Schulert. And in almost every case, the development of this lung disease seemed to follow treatment with IL-1 or IL-6 directed therapies, or specifically in the context of them. And Vivian's paper specifically noted the presence of very common atypical features in these cases. The presence of eosinophilia, or high levels of the white blood cells called eosinophils, which are part of the allergic response. Atypical skin rashes that are not typically seen with systemic JIA, and anaphylaxis, or severe allergic reactions to tocilizumab. So this may represent the syndrome of a drug reaction with eosinophilia and systemic symptoms, or DRESS. DRESS is a severe drug-induced hypersensitivity reaction that can be highly fatal if untreated. 10 to 20% of cases of DRESS would die without treatment. And it's associated with inflammatory features, which include eosinophilia, a skin rash, which can have a lot of different kind of appearances or presentations, like the ones that we've seen in our patients, as well as swollen lymph nodes and abnormal white blood cells and inflammation of the organs, and all of this happening in the absence of an infection or autoimmunity. And so all of these features are captured in a nice classification score that's used by allergists and immunologists called the REGISCAR score. The REGISCAR score puts together these clinical features and defines if a person has DRESS. And so a person is generally considered to have DRESS if they have a score of 4 or greater in this probable DRESS category. And so we wanted to determine whether the subjects with the apparent hypersensitivity actually had DRESS. And so to do this, numerous collaborators from around the world worked together to try to aggregate clinical data and to apply the REGISCAR scoring system to a group of systemic JIA patients with lung disease and this apparent hypersensitivity, as well as to another group of 65 children with systemic JIA who had been treated with cytokine inhibitors and had never developed any evidence of hypersensitivity. We call these the drug-tolerant systemic JIA or drug-tolerant Still's cases. And so in looking at these groups of cases, 65 with hypersensitivity, of whom 47 had lung disease, we found that all of them were classifiable under the REGISCAR scoring as hypersensitivity of the DRESS type or DRESS. The vast majority of them even scored in the highest range of definite DRESS, which only points out the fact that the features that were characterized as DRESS were actually in the severe spectrum of DRESS. But of equal importance was the fact that none of the 65 drug-tolerant controls had a REGISCAR score over 3 or could be classified as DRESS. So from my perspective, this pretty clearly indicates that the suspected hypersensitivity that we saw in these subjects is actually DRESS. So when the clinical features are compared between the systemic JIA DRESS cases and the drug-tolerant Still's cases, there's 3 features that were strongly associated with this hypersensitivity DRESS reaction. One was peripheral eosinophilia or elevation of the eosinophils. One was elevation of the liver enzymes, the AST and the ALT. And one was the presence of macrophage activation syndrome or cytokine storm. And all of these differences were highly significant and had very large effect sizes. And based on this analysis, the development of any of these clinical features while somebody is being treated with cytokine inhibitors for systemic JIA need to raise concern about whether this type of reaction might be going on. DRESS is actually known to be associated with specific HLA types, and it happens in response to specific medications. And there are often pairings of a type of medication that causes DRESS in people with a certain HLA type. For this reason, we wondered whether we could identify an association between a specific HLA type and the development of DRESS in these kids with systemic JIA receiving these biologic medications. So to do this, we determined the frequencies of the classical HLA types in the kids with systemic JIA and DRESS, and we went back and we compared them to the genome-wide association study cohort, the in-charge cohort, in which we had determined all of their HLA types. For the sake of time, I'm going to emphasize 2 key findings here. The first finding was that the one specific HLA type, the HLA-DRB115 type, was strongly associated with systemic JIA DRESS. The effect sizes were very much out of proportion to what we see for a typical HLA relationship with the disease, which would be somewhere in the ballpark of an odds ratio of 2 or maybe 3. In this case, the odds ratios are 15 or higher from our analyses, which is a very large risk factor. And more specifically, these types of alleles, HLA-DRB115 alleles, were present in 85% or more of the systemic JIA DRESS cases and less than 25% of the systemic JIA cases in general. The second point I want to make is that this effect transcended ancestry. And this is important because HLA alleles occur at different frequencies in populations of different ancestries. So you can't compare people of ancestry A with ancestry B with one another. But when we take the controls away and we just look at all of the cases, by all ancestries or breaking them down by their self-declared ancestries, we see that the majority of cases by every ancestry shown in the dark gray boxes have one of the HLA-DRB115 alleles. So again, this is just another striking demonstration that these HLA-DRB115 alleles transcend ancestry in their relationship with this DRESS phenomenon. So these findings will need to be validated in both longitudinal cohort studies and prospectively, but the HLA association here is strong and it's clear, and the effect size is consistent with those that have been observed in other cases of DRESS that are linked to HLA alleles. And so if this relationship is true, this association between DRB115 alleles and cytokine inhibitors is confirmed, then HLA screening prior to initiation of biologic treatment needs to be considered. Foreseeably, this could become the standard of care. And moreover, awareness and early recognition of these clinical features that might identify early this phenomenon will become critical. So with respect to can we predict who will get systemic JIA lung disease? I think the answer is maybe. We can identify individuals who are at high risk for developing systemic JIA DRESS, those people who are bearing the HLA-DRB115 alleles. And we do know that all the children in our study who have systemic JIA lung disease classified as DRESS. So there were no cases in our study who had lung disease who didn't have DRESS. So I guess by the transitive property, you can predict that people who have HLA-DRB115 alleles and are at risk to get DRESS are also at risk to get lung disease. The other caveat being there were people who had the DRB115 alleles who did develop DRESS, but who didn't get lung disease. So it's not a completely linear path. We don't completely understand this relationship. But just because we don't completely understand it, that doesn't diminish the importance of what we've observed so far. All right, so just to briefly summarize the headlines that I've discussed with you here today. First, we discussed a couple of new studies that are supportive of the biphasic model of systemic JIA, which really underlies the therapeutic window of opportunity to alter the disease course of systemic JIA. Second, we discussed the current state of personalized medicine in systemic JIA with the focus of the mounting evidence of IL-1 receptor antagonist variants that might be used to prospectively identify anakinra or canakinumab non-responders, as well as emerging reports, the first emerging reports of biomarkers, both gene expression profiles and serum proteomic biomarkers that might predict response to canakinumab. Next, we discussed a study that asked whether sustained remission upon dose reduction or dose interval reduction of canakinumab in patients with stable, previously stable remission. And we saw that it wasn't clear that remission is durable and that upon the reducing of therapy, that the majority of patients had recurrence of active disease. Now, the tapering of medications presents the opportunity for patients who have the monophasic pattern to be taken off therapy, and that's a lifelong removal of therapy. So I do think that there's still some value in continuing to pursue this therapeutic reduction, but we have to keep in mind that it's important that we be able to reclaim the clinically inactive disease or remission in the people who don't have the monophasic disease and the people in whom inflammation recurs. And finally, we discussed the lung disease that's been reported in systemic JIA in conjunction with cytokine inhibitors, and the new investigations that have realized that the lung disease is developing in the context of hypersensitivity that's classifying as DRESS. And I think it's important that these subjects that are developing DRESS after treatment with cytokine inhibitors are highly enriched for these HLA alleles, which means that if we were to screen for those alleles, we could theoretically reduce the risk for those people. So this was a whirlwind tour of things that have emerged in systemic JIA. And I'd like to thank you for your attention. And I see it looks like we have 8 questions in the chat so far. So at this point, why don't we go ahead and get to your questions?
Thank you, Dr. Umbrello. Let's start with, I think, the first one. Craig, I think we'll just see if you still have this question, but have these studies been done with Actemra? So this is Craig Glacken's study or question.
Yeah, doctor, anything done or studied along the IL-6 blockers along the line of Because this is all IL-1, right? We done studies like that as well?
You're talking about for the personalized medicine, things that might predict response to Actemra.
Yes.
There are no studies that have predicted response to Actemra at this time. When we looked at so of course the markers that we looked at for anakinra response were intuitive because it was the protein that is anakinra. There's no similar relationship between variants in the IL-1/6 gene and response to IL-6 directed therapy.
Okay. Thank you.
That doesn't mean people aren't looking for those. It's just they haven't been found.
Yep. Okay.
There was a comment by Carrie about 92% in clinical remission if treated within 3 months of onset. Wow, if we can only get everyone there. I would just echo that. When listening to your talk, it just struck me, the quicker we get these kids in remission, the better for them in terms of their life, their activities and whatnot.
And that's a lot of what the Dutch groups have shown. Bas Bostert, and Ninka and the folks in the Netherlands and his group have really implemented early therapy for everyone. And the numbers that they quote are really striking. And at the beginning were difficult to believe. Even if you consider the 40% of them are monophasic, they're still having very good responses. I think that the longitudinal follow-up studies are important because I think that over time you'll see some attrition of the response rates. But if I don't think 92% is a realistic number with respect to response to anakinra. So
yeah, but I mean, hugely important work. This is such important work for these kids and their families. Okay, so with HLA-DRB15 screening becomes standard in SJIA, do you think?
I think it's, it depends on how things evolve, but if what we're showing is validated or replicated by another group, it's going to be hard not to do that because, that relationship is very strong. It's going to be necessary to figure out what's underlying that hypersensitivity. That's the key thing, because we're dealing with 3 structurally different proteins. And so what is the common factor in those things that's driving this hypersensitivity, and what can we do about it?
Mm-hmm. And Rochelle has a question. Are you seeing many children with SJIA and MAS with overlapping conditions? All those conditions listed? You're able to see the question?
Yes, so Mrs. Lentini, we are seeing SJIA, MAS overlapping with immune deficiencies, including hypogammon CVID, definitely with Crohn's disease. I have not seen it with ankylosing spondylitis. That would be a bit atypical, but I won't write anything out. I'm not sure whether allergies will or won't be truly pathophysiologically related. There is a lot of people who have allergies who also have systemic JIA. I guess only big studies will show if that trend is more than just a coincidence. Vasculitis, so this gets back to systemic JIA being kind of an overarching phenotype or a common endpoint, because there are people with vasculitis who could fulfill criteria for systemic JIA if they didn't have the laboratory tests to show that they had vasculitis. And so gastroparesis. So gastroparesis is an interesting one because that fits into the kind of group of dysautonomia or autonomic dysfunction. In my protocol, many of the people who come to me are self-referred. And there's some people who come who the child clearly has, or the adult clearly has adult stills or systemic JIA. And there's others where they have something that could be systemic JIA, but is different than systemic JIA. And there's some who have an autoinflammatory disease that somebody called systemic JIA that clearly looks different. In that third group of things, there are a lot of people with dysautonomia. And that's something that's striking to me and has me thinking beyond systemic JIA about how dysautonomia and autoinflammation can be working together. Maybe in people with Ehlers-Danlos and true molecular connective tissue diseases. I'm talking about this a lot, but the point is that that's something that's an area of interest to us outside of systemic JIA, this kind of dysautonomia with autoinflammation.
So he has dysautonomia too.
So from my perspective, if someone has dysautonomia, I would, in my mind, be thinking really hard about whether this is a monogenic disorder or something that's different than systemic JIA. When people come to see me, I don't want to change the name because the name doesn't really matter. What what I'm thinking about is, do I think there's going to be a single gene cause for what's going on? And when people have something that's not the run-of-the-mill systemic JIA, rash, fever, lymph nodes, nothing else going on, I think that those people should be sequenced because there's something to be learned.
Can I call you?
Yes, anyone can call me. I always make statements at the end of my talks about wanting to recruit people and wanting to sequence people. And I know there's people across the country that are doing sequencing. In my study, my goal is to sequence 2 parents and 1 child for every affected child. And by doing that, that helps me to immediately write off the chaff and find the things that either developed when the child was embryologically developing or the things where they inherited 1 hit from each parent. Those are most likely going to be the driver mutations. Other studies where people are just looking at the children, these people want to collaborate with me, but it's hard to put those data together with our data because I want the parents to filter the kids. So
Can I ask you one more question? Have
Please.
you seen kids get the interstitial lung disease and then have it repair? Because that's what happened to him.
So there, I have several people who I've seen and follow in my cohort who've had that pattern. It didn't necessarily happen in front of my face because I don't have the benefit of seeing you all on the regular basis that your primary doctors do. However, I know that there are people who had there's no one who had clubbing of their fingers who had resolution of their lung disease over time. However, there are people who had early changes of bronchial thickening on a CAT scan or a chronic cough or some other features who have had those things seem to resolve over time with removal of the medications. So it does seem that.
Okay. So it's medication related.
Well, so we hypothesize it's medication related because every child who we saw that developed this hypersensitivity did so in the context of being treated with either anakinra, canakinumab, or tocilizumab.
Okay, that explains a lot. Okay.
Okay, thank you. You have a couple people who are interested in this dysautonomia, and they're asking if you could talk about your study and give your contact information, perhaps, how to reach you.
Sure. So I'll share the screen again here, if that's okay with you.
You can put it in the chat if you're willing to.
Of course. So my study is NCT 035104442 on clinicaltrials.gov. My email is michaelumbrello@nih.gov. Thank you very much, Mrs. Bush. Mrs. Bush has the flyer for our protocol as well.
Okay.
And I had wanted to get my protocol flyer fixed so I could share it on Twitter because I felt like that might be a reasonable way to reach people as well. But our IRB needs to approve things before they can be put on social media. So, so as it relates to dysautonomia, I had wanted to avoid it because I'm not a neurologist and I'm not an expert in dysautonomia. And so that's really taking me someplace that I'm very much A, out of my comfort zone, and B, not feeling like I have a lot to provide in terms of help. But when I see how helpless a lot of the kids are and the adults are who have the dysautonomia and how few people there are, I've tried to step in a little bit more and at least see people, evaluate them, take a history, and trying to meet people in the dysautonomia community that I can network with to either co-evaluate patients or refer patients. And so I don't want to give the misperception that I'm a dysautonomia expert. It's more the fact that I see the pattern and I'm not going to ignore it anymore.
Great, thank you. Also hugely important. Also a mother who has dealt with some of that. So I wanted to just check in with Katie. Katie, we're running to the end of our time. Should we go for a couple more questions or should we wrap up?
Sure, I think we could do a couple more. I may need to run to start the next session, but you guys could finish up a couple more.
Okay, sure. We have a question. I'm going to jump to the bottom first, but my daughter has MAS in the liver tissue numerous times. Has there been any cases you know of? Only drug that has helped has been Gamifant.
Yeah, so this is a great question. at the beginning of someone's course, when they have MAS, and if they don't respond to treatment, or if they start to show patterns of recurrent MAS, I think it's important to look for the genes that we know that cause primary HLH, the molecular type of MAS. And I'm going to assume that that was probably already checked in your child and that those things weren't there. The thing that I keep in the back of my mind is that there's a substantial number of people with HLH for whom the causative gene is not known. And there's discovery of new genes that cause HLH all the time. So when somebody has recurrent MAS with systemic JIA, I really think more about their treatment as treating them with an HLH type protocol as opposed to a systemic JIA type protocol. Not giving medical advice on a teleconference, but every case like that, I do want to go back and review to make sure that there's not the chronic driving of inflammation by a hypersensitivity reaction, because that's one other thing about the hypersensitivity. The type of inflammation that it causes in a systemic JIA case can be pretty easily confused with the cytokine storm of MAS. And so in that circumstance, I wouldn't fault anyone for thinking that it was MAS instead of hypersensitivity. And so making sure that it's not one of those other things, and then really approaching it more like HLH in its treatment. The fact that it only responded to Gamifant also is consistent with that approach.
Great, thank you. Dr. Umbrello, do you have time for one more question?
I do. I'll stay as long as people want to ask, as long as you
Thank
guys.
you. You've gotten many very appreciative comments in the chat about how passionate you are for our children, and it's very much appreciated. But I want to get to Leah's question. I believe you mentioned a subset group with bowel issues and SJIA. Was that due to the overall systemic inflammation or a secondary issue? And then we'll call that the last question.
So that's a great question. It's not completely clear. Betsy Mellons published just a case report that showed there was a correlation, a subset of kids who could also be said to have Crohn's disease or ulcerative colitis. They were colonoscopy positive for inflammatory bowel disease. In my cohort, there's several patients who have that. There's one who has a clear mutation that's going to be causative of that. In her case, I haven't found anyone else who has mutations in that gene. There's a group from Germany that just sent us a subset of patients who have inflammatory bowel disease with systemic JIA that we're going to sequence and perform RNA sequencing to try to get to the bottom of this a little bit better. But that's one of the phenotypic subgroups that I'm interested in trying to build and then compare back to both the bigger systemic JIA group and the hypersensitivity group and the MAS group as we try to glean more information through these different comparisons.
Great, thank you so much. So on behalf of all of the parents who are on the call today and those attending the Arthritis Foundation, we thank you so much for being with us. It is incredibly helpful, and we're very appreciative of learning of all of these updates and everything that we can about arthritis for our kids. I also wanted to thank the Arthritis Foundation. I wanted to thank the planning committee for all of these great talks with the SJIA groups. And I think we're going to hop now, take a quick stretch break. And those who want to catch the next session, we start in about 10 minutes.